Recording. Perfect. So we are very pleased to have Dr. Andrew Moore here with us. He's a pulmonary and critical care medical fellow at Stanford. He grew up in Virginia and completed his bachelor's in neuroscience at the College of William and Mary, followed by his MD at the University of Virginia School of Medicine, and his residency and chief residency here at Stanford School of Medicine. As a fellow here at Stanford, his research focuses on use of bioinformatics and to develop better diagnostic and prognostic tools in the ICU. So he has a very busy schedule, and we are so lucky that he gave us his time with the busyness that he has in the ICU. But we are really pleased to have you, Andrew. Thank you so much. Please take it over.
Wonderful. Thank you so much, and happy to be here and happy to be re-invited to talk about this topic, which I think is really, really important. I think how we communicate amongst ourselves and how we communicate with our patients is incredibly important. So I'm really happy to have the opportunity to talk through sort of my thoughts on it. So I will go ahead and put my slides up. And then I think one of the important parts of this is I really do want this to be interactive. And so I've included a Google Drive link to some of the sort of common terminology that we'll be using throughout this presentation as we sort of go through it. So let me go ahead and share my screen. And then we can go ahead and get started. Apologies, 1 second. There we go. Okay. All right. So hello, everybody. My name is Andrew, and I've been charged with doing a rapid intro to medical terminology. To start off with, I just want to say no relevant disclosures of financial interest, as much as I wish that was the case, but nothing pertinent to disclose here. So here are our objectives for today. So ideally, at the end of this lecture, you'll be able to interpret key roots, prefixes, and suffixes for medical terms. You'll be able to apply important anatomic terminology. You'll recognize the importance of acronyms in medical practice. You'll understand when the use of medical acronyms is appropriate and when it should be avoided. You'll be able to apply common medical acronyms, abbreviations, and colloquialisms. And then most importantly, I think, identify and use resources to improve health literacy. So as far as nuts and bolts, we'll start off with a bit of a lecture as to why terminology is difficult, methods we can use to simplify it a bit. And then for most of the course, we'll be practicing with some common and then not so common terms and phrases. And for the interactive portion, as I mentioned, we'll be using the medical terminology cheat sheet, which I've included. So if you don't have access to that, send us a message and we'll try and get that to you, okay? So when I think of medical terminology, I think of it almost like a different country. And I think country is very important because it's not just language that's the barrier. There's this huge cultural component to it that goes well beyond just language. So most people in the healthcare field are pretty crazy busy. So most of us talk way too fast. And we use a ton of shorthand to try and maximize efficiency. And even when you get past the shorthand, you look it up on Google and figure out what exactly that shorthand means. That shorthand is then just a term that you have no idea what that means. So then you have to go look that up. And then once you get there, it's a term about an unfamiliar disease. So, 5 lookups later, and you're still no closer to figuring out exactly what's going on. And then beyond that, once you get past the language barrier, everyone has sort of different customs. So I talk to a surgeon very differently than I talk to my medicine colleagues. And we talk to sort of all different levels of healthcare professionals. And all of them have sort of different customs and different ways of speaking, which is incredibly confusing. And then finally, hospital systems are confusing just sort of physically. So it's easy to get lost, not know where you are. So I find it all just incredibly bewildering. I love seeing like the first day of July when all the new interns come in and they're just totally lost, wandering around the hospital, no idea where they're going, no idea what they're doing. And so all of us have seen this, all of us know this feeling. So it's incredibly common and important for us to sort of recognize that. So how in the world do we start to simplify this? And I think the important thing is to start with the language part, right? So the language part is the easiest to break down. It's the easiest for us to sort of figure out. And I recognize that this is going sort of back to grade school, but I think it's important to think about like what these words are made up of, because medicine is very formulaic. It's fairly easy to get through a word if you know what you're looking at, right? So this is sort of breaking it down. So remember that the root is the central topic of the word. Usually it's the disease, the procedure, or the body part that you're discussing, right? The prefix is the modifier before the word. It's generally focused on giving additional anatomic information or specifying time and quantity. And then finally is the suffix, which is a modifier after the word root, which usually provides information on what is occurring with the word root, right? And so all together, you put this together and we're going to demystify language. So I'm going to start with prefixes. So prefixes are the very beginning of the word. So it seems like a pretty good place for me to start, right? And remember that prefixes usually try to give additional information about the topic, often providing anatomic or quantitative information. So like Dr. Seuss is just describing how many or what type of fish we're discussing, right? So let's start with ones that denote quantity. And all these are things that we see sort of day to day. So it should be fairly intuitive, right? So a unicycle is a bicycle with one wheel, right? A bicycle is two-wheeled. A tricycle is three-wheeled. A tetracycle, never seen one of these in real life, but apparently they exist, four wheels. These are a little less intuitive. So oligo refers to a few things. And we often use this to describe the distribution of a disease. So for instance, oligoarthritis describes inflammation involving just a few joints, usually 2 to 4. And so when you say that to a medicine doctor, it gives us a very different differential than say a monoarthritis or a polyarthritis, which describes many joints. So when you have more than 4 joints, or some people say more than 6 joints, you call it a polyarthritis, and that carries a very, very different differential, a much more systemic process, right? And then sometimes you have too many, and that's when you term it hyper. I would argue that this is probably too many bicycles for this snow slope. Micro, again, fairly intuitive, is a small. And then hypo is too small, way too small. And then macro or mega is large. So hopefully all of these make sense. And when you combine them with the root, it helps you to sort of figure out what's going on with it. Now, other prefixes denote location and time. So these we don't see quite as often in sort of regular life. This is a fairly common one that I think is relatively important. It's abduction and adduction. So AB means away from and AD means toward. This is most often used in neuromuscular testing, where abduction is away from the center and adduction is toward the center. And describing this accurately plays a really important role in localizing neuromuscular and joint pathology. So often we do use these words. Ambi means both sides. So ambidextrous is when you're able to use both hands equally. Pre and post are things that we see relatively commonly. So remember, pre happens before, post happens after. And then you have ecto and endo, which are antonyms. So ecto and endo, and ecto and exo mean outside of, and endo means inside of. So the endometrium is the lining of the uterus. And an ectopic pregnancy is a pregnancy that lies outside of the uterus, most often in the fallopian tube, and carries very severe consequences. These are sort of important anatomic terms. So infra and sub, juxta and para, and super and supra. So I use this in terms of a location of an intra-abdominal aortic aneurysm. So this is a ballooning of sort of your large blood vessel in your abdomen, your aorta. And where it is relative to the renal artery is incredibly important. So these are your renal arteries right here. This is your abdominal aortic aneurysm. And where it is relative to the renal artery carries an important information about how high risk it is, how likely it is to cut off blood flow to your kidneys, which is incredibly important, and how difficult it is to repair. Because often we place stents, and what we don't want is a stent to cover up the renal artery. So this is how we describe our intra-abdominal aortic aneurysm. So a suprarenal AAA happens above the renal arteries. A pararenal is right at the renal arteries. A juxtarenal is right next to it, very close to it. And then an infrarenal is below it. And so an infrarenal is your lowest risk AAA, much less urgent to repair, whereas a suprarenal AAA requires much more time, much more intensive, and is higher risk. Next up are qualitative prefixes. So this is helping us to figure out what a topic is doing. Is it good? Is it bad? How is it shaped? Things like that. So anti is against. So for instance, an antibody is something that binds to proteins in the body. Whether that's good proteins, bad proteins, tough to say. But an antibody is something that binds to proteins. Auto refers to yourself. So for instance, autoimmune disease is when antibodies inappropriately target our own antigens, causing things like lupus, rheumatoid arthritis, multiple sclerosis, etc. U is normal. So for instance, euthyroid is when your thyroid levels are normal, compared to hyper, which is high thyroid levels, or hypo, low thyroid levels. And then dys is abnormal. So for instance, dysreflexia is when you have abnormal reflexes. Dys doesn't necessarily have to be bad. Mal is much more specific to being abnormally bad. So a maladaptive process, malaise is feeling bad overall. So dys is just abnormal, whereas mal is abnormal, but in a bad way. Morph is the shape of something. So sometimes we can make a morphologic diagnosis by looking at the shape, either sort of grossly, which is when you look at the tissue, or at a histopathologic level where you actually look at it under a microscope. And based on that, you can make a morphologic diagnosis. Pseudo is false. So going back to our aneurysms, a true aneurysm, like a AAA, is when you have all three walls of the vessel expanding, whereas a pseudoaneurysm is when only one wall of the vessel expands and the rest of the vessel is intact. Now you can imagine that this is really important because a pseudoaneurysm carries both a different way of treating it in terms of how you cover it and a different risk. So because it's just one single lining, it has a much higher risk of bursting and can cause much more significant bleeding. So a large pseudoaneurysm is more worrisome than a large aneurysm in many cases. So that sort of goes through all of our prefixes. And again, you should have a sheet that goes through these later, and we'll actually give a lot more examples of this in just a little bit. Next up, we have suffixes. So suffixes, I think of as the sauce, not just because they have the same letter and sound kind of similar, but they really are what carries most words. So usually the topic itself is kind of bland. Like I wouldn't want just like pasta by itself. But suffixes are there to tell you what's actually going on in a given word. So I'm going to use myo as an example. So myo is the root, and it refers to muscle. And suffixes are going to sort of spice it up a little bit, right? So myalgia is pain in the muscle. So this can be normal if you had a good workout, or it can be abnormal if you have a muscular disease, such as myositis. So myositis is abnormal inflammation in the muscle and can present with abnormal myalgias, so muscle pain, and muscle weakness as well. A myoma is a tumor. So what we're looking at here are actually leiomyomas. So we can add a prefix to it, which are smooth muscle tumors in the uterus. And sort of the common colloquialism for this is fibroids. There are also procedural suffixes. So this tells us what's actually being done to the root. So a myectomy is a procedure in which we resect the muscle. So this is showing a septal myectomy. So this is your heart, this is your left ventricle, this is your left atrium. And what you can see is that in a case, and there's a condition called hypertrophic cardiomyopathy, in which there's abnormal growth of this muscle, which blocks blood flow through the aorta. And that muscle needs to be removed. And so we'll actually go in there and we'll cut out that muscle, and that's called a myectomy. A myotomy is an incision. So instead of removing the muscle, we just cut through the muscle. So one example of this is for acronyms, which is a condition where the muscle is abnormally innervated so that it's too strong. And so food can't get through the esophagus into the stomach. And so what we do is we just cut into that muscle and then we loosen it up so that food can get into the stomach appropriately. And so that's called a myotomy. And this particularly is called a Heller myotomy. Suffixes can also denote action, like what is happening to certain roots. So I'm going to use heme as an example. So heme means blood, and it can mean a variety of parts of blood. But for instance, hemolysis is the breakdown of blood. So what I'm showing you right here is something called a schistocyte, which is a helmet cell. So this is actually red blood cells that have been broken down and as a result are abnormally shaped. And that's the breakdown of blood. Hematology is the study of blood. Hemophagocytosis, this is a big one. But remember that phagia is eating. And so hemophagia is when your blood is eating your blood. So this is where your macrophages, which are a sort of a cell that allows you to eat things up, are eating some of the red blood cells and white blood cells in your body to try and clean things up at a wound site. Hematopoiesis is the production of blood cells. So remember, you start with stem cells and then they turn into all the various cells in your body. And that's the process of hematopoiesis. Now, the thing that gets a little bit confusing is that sometimes you don't have a root at all, which is just further proof that roots are just kind of bland. Sometimes you can add a prefix to a suffix, and that gives you all you need to know, right? So a good example of this is aphasia, which is lack of speech. So this is where people lose the ability to speak, often because of a stroke. Atrophy is when you have lack of growth of a muscle, or actually ultimately like loss of muscle mass. Apnea is lack of breathing. So many of you have probably heard of sleep apnea, which is a condition where you're not able to breathe at night because of either obstruction or a central nervous issue. So that's all sort of the suffixes. Now I want to get into the roots. So finally, we get to sort of put it all together. And this is where I think now that we've gone through prefixes and suffixes, I want you all to sort of take the reins on these and actually go through a couple of them. So I split up the roots into sort of general medical roots. So these are things that are applicable to sort of all subspecialties. And then also more specialized things based on neurology, eyes and ears, nose and throat, etc. And since we've already gone through prefixes and suffixes, what I want you to do for this next set is I'm going to give you all a word, and then you'll have a minute to decipher it, and then send it our way in the chat. And then we'll go over it all together, okay? And so hopefully you all have that sort of roots and prefixes and suffixes sheet that I sent you, and we'll be able to work through this together and talk through some of the nuance of it. So I'll start with meningitis. Perfect. So I think y'all all got it. So that's exactly what it is. So it's inflammation of the meninges. So what in the world are the meninges? So the meninges are a layer right under the skull that covers the brain. So it's an incredibly important part of the brain. It's where a lot of sort of the blood vessels, lymphatics, et cetera, run. And inflammation of this is abnormal, and is a really, really severe infection and is a medical emergency. So it's an incredibly important thing to recognize, and honestly quite difficult to treat as well. All right, great job. So next one is Otalgia. Perfect. So I think everyone got it. And thank you all for putting in the chat. It's so much more just like rewarding to have some communication in these Zoom chats. It's so easy to just go silent. So Otalgia is pain in the ear. And so it can mean a number of different sort of pathologies, but ultimately this is a symptom that patients present with. And then healthcare professionals sort of have to work through sort of where is that pain coming from, et cetera. All right, and Encephaly. This is a long one. Oh, we might have tripped y'all up a little bit. So we'll go through this one. Oh, here we go. Yeah, so that's exactly right. So an means absence, and cephal means head. So anencephaly is absence of a portion of the skull and or brain. And so this is a condition at birth that leads to lack of mostly sort of the posterior portion of the brain as well as the skull, and is incredibly, incredibly difficult. All right, muscular dystrophy. Yeah. So that's exactly right. So y'all got it right on the head. So dys is abnormal, trophy is growth. So this is abnormal growth of muscle. And I actually think that this is kind of an interesting nuance here in how we talked about it, because it's not that muscle doesn't grow, right? Muscle is trying to grow, but the muscle is growing abnormally. And so this leads to a relatively severe condition that ultimately can lead to sort of respiratory failure and death. And it really comes down to this abnormal production of muscle leading to weakness. All right, apraxia. Yeah, that's exactly right. So A is absence, prax is movement. So apraxia is the inability to perform certain movements. And this is kind of an interesting condition. So it's usually the result of a stroke or a central nervous system disease. And it ultimately leads to inability to do certain actions. And usually it's very specialized actions, not even just like single movements or anything like that, but it's instances like having difficulty buttoning up your shirt or writing or things like that are examples of apraxia. So they're usually very sort of fine motor movements that people are unable to perform due to a condition. All right, hyperalgesia. I love it. That's emphatic. So that's exactly right. So hyper is too much. Algia is pain. So hyperalgesia is increased sensitivity to pain. And so there are a number of different conditions that can cause this. And it really ends up being a condition where your brain and nervous system are overactive. And it's incredibly difficult to treat. I think pain is one of the sort of next frontiers of medicine where I don't think we fully understand why people have this increased sensitivity and how to treat it. So hopefully in the coming years, that'll be something that we develop over time. All right, so now we're getting into sort of like spaces. And anatomic stuff. So what is a retropharyngeal space? Yeah, so retro is behind, pharynx is the pharynx. So this is the space behind the pharynx. And this is an incredibly important space. So I bring it up not just because I think it's a tough one to read, but also because it's important. So remember that your pharynx is sort of this sort of part in your throat right here, travels all the way down from your nose, all the way down to your vocal cords. And there's a space behind it called the retropharyngeal space. So it's right in here. And the important thing for this is that it's very close to the mouth. So it's apt to get infections. So people can get sort of strep infections in this space. And then more importantly, it's a direct conduit to your mediastinum, which is the space that surrounds your heart. So if people get these retropharyngeal space infections, it can travel all the way to the heart, which is why knowing where it is important. Being able to explain where it is important, and then knowing how that sort of anatomic connection is present is important in terms of like defining the importance of this illness. Coratoplasty. Yeah, so that's exactly right. So Corato is actually the cornea, and this is tricky because the keratin is present in a lot of different spaces and is present in your skin in a lot of different spaces. But in general, Corato speaks to the cornea, and then plasty is surgical repair. So this is corneal surgery, and usually is corneal transplant. So this is a situation where you do a corneal transplant for things like oh my gosh, I'm blanking. Why can't I think of the word right now? Sorry, I've been on ICU nights for like too long. But anyway, but anytime you need a sort of corneal transplant, that's called a keratoplasty. Yes, well, not so much. Yeah, anyway. All right, so then next up is exophthalmos. Yeah. So exophthalmos is when, so X is out, ophthalmo is eye. So exophthalmos is actually bulging of the eye. So this is commonly seen in thyroid disease, in particular Graves' disease, because the antibodies that are produced in Graves' disease not only attack sort of the thyroid, but also attack the fascia and the soft tissues in the eye and cause that bulging. Interestingly, even treatment of sort of the antibody doesn't always treat the exophthalmos, so it's a difficult thing to treat, although we've gotten a little bit better at it recently. Next up is tracheostomy. Yeah. So everyone's exactly right. So tracheo is trachea. Stomy is an opening. So it's when you actually open up the trachea, create a hole there, and then usually it's used to access it for a breathing tube. So a tracheostomy is when you create that hole, and then you actually put the breathing tube in there. And then we also call that the tracheostomy tube, shortened as tracheostomy. So this is something where patients with long-term respiratory failure or issues with their vocal cords or the pharyngeal space require this to be able to sort of bypass the vocal cords and be able to breathe long-term without requiring a tube that goes through the mouth and prevents them from being able to speak, etc. And then we're approaching the end here. So adenocarcinoma. Yes, I love that specificity. So adeno is a gland, carcin is cancer, oma is tumor, right? So adenocarcinoma is a cancerous tumor composed of glandular tissue. And all this is incredibly important. Like all these little details, I think, help us to figure out exactly what we're talking about, right? Because there are a lot of different kinds of cancer. Not all of them produce a tumor. And there are different locations from which the cancer can come from, right? So an adenocarcinoma is a cancer that's arising from glandular tissue, most commonly in places that are constantly being replenished, right? So you have glandular tissue in your lungs, in your stomach, in your gut, that constantly sort of secrete mucus and then are broken down. And the fact that they're constantly broken down that way is why they're at risk of cancer. Why adenocarcinoma is the most common type of cancer that we have is because of that sort of constant breakdown, constant buildup phase, and that high risk for mutation as a result of that. Whereas things like your sort of soft tissue, your bones that aren't constantly growing are much lower risk for cancer. Not to say we don't get cancer there, but they tend to be much lower risk. So adenocarcinomas are the bulk of cancers. Acoustic neuroma. Yeah. So acute is ear, ner is nerve, oma is tumor. So it's a tumor of the auditory nerves. And again, this isn't a cancer necessarily. This is just a tumor, right? So there's a difference between, there's a wide variety of different tumors. And the fact that this isn't a carcinoma is important. That doesn't mean it's not severe. It doesn't mean it doesn't need to be removed. It just means that its growth pattern is slightly different. And this in particular is a common cause of hearing loss, particularly in young people. And also, I just figured out what the keratoplasty was for. It's for cataracts. I don't know why that took me so long to remember that, but cataracts. All right, polyarthritis. Yes, this is perfect. So poly is many, arth is joint, itis is inflammation. So we talked about this before, about sort of the difference between a polyarthritis, oligoarthritis, monoarthritis, right? So a monoarthritis is one joint and tends to be suggestive of sort of a singular joint issue, either trauma, like a hemarthrosis in a single joint, or an infection. So septic arthritis tends to involve just one joint. Whereas a polyarthritis is a much more systemic process, such as osteoarthritis, rheumatoid arthritis, lupus, things like that tend to cause a polyarthritis. And so this is why we discuss these things and why it's important to sort of differentiate them. Enterocutaneous fistula. Yeah, so this is an incredibly difficult condition. So entero is intestine, cute is skin. So an enterocutaneous fistula is an abnormal connection between the intestines and the skin. And it most often happens after abdominal surgery or severe infections, where you have a scar and then the intestines, because of the abnormal inflammation that's going on, actually attaches to that skin and then actually has a conduit outside of it. And it's incredibly difficult condition, incredibly difficult to treat, because you can imagine that more treatment just leads to more inflammation and leads to more problems. So incredibly difficult condition, but a good example of using these sort of terms. Yeah, so an enteroscopy is something that most of us know colloquially. So an enteroscopy is your intestines, scope is observed. So it's evaluation of the intestines, usually done with a camera. So colonoscopy is example of an enteroscopy, or you can do it from the top, which is an esophagogastroduodenoscopy, which is a type of enteroscopy. There are also a number of other scopies. So there's thoracoscopy, which is when we go in through the ribs and look at the lungs directly with the camera. There's bronchoscopy, which is when we go through the mouth and look into the inside of the lungs, the bronchioles with a camera. There's laparoscopy, which is when we go through the abdominal wall and look at the intestines with the camera. So scopy is sort of a general term, and then in the front of it is sort of what we're actually looking at. Costochondritis. Yeah, so this is a difficult one. So costo is rib, conj is cartilage, and itis is inflammation. So costochondritis is inflammation of the cartilage of the ribs and is one of, if not the most common cause of chest pain. So when people come in with chest pain, we often try to differentiate why they're having chest pain. Is it a heart attack? Is it a pulmonary embolism? Or is it just costochondritis? And there are a number of sort of tools that we use to think about this. But it's an important term to know. Rhinorrhea. Yeah, so rhinorrhea, so rhino is nose, rhea is fluid discharge. So most often it's a runny nose, right? And so there are a lot of different causes of runny nose. Infections, allergies, abnormal fluid buildup, any number of different things can cause it. But this is the symptom, and it's a symptom that's probably going to be very common very soon as we head into fall. And then lithotripsy. Yeah, so everyone's exactly right. So lith is stone, tripsy is break apart. So lithotripsy is a procedure that breaks apart stones. And so there are a lot of different ways to do this. So for kidney stones, for example, where this is most commonly done, you can use shock waves, where you actually just target waves sort of at the stone from the outside. You can use lasers, which sounds really cool, looks less cool in person. But you go in and you actually use lasers to break apart the stone. There's also gallbladder stones, and so lithotripsy can also refer to gallbladder stone breakup, although we usually sort of specify that a little bit separately. So this is a long one, but gave you all a little bit of a hint earlier. So chole is bile, doco is duct, lith is stone, iasis is a condition. So all together, you put that together and it says stones in the bile duct or gallstones. So gallstones are an abnormal condition. Usually the gallbladder is just supposed to store bile, but often the gallbladder will actually make stones because they bind up. And then when those stones get stuck in the bile duct, that's a big deal and can lead to severe infections, pain, etc. And then laparotomy. Yeah, so this is an actually really difficult one, and one that we get confused about on wards quite a bit. So laparo is abdomen, tomy is incision. So laparotomy is abdominal surgery with open incision, as opposed to laparoscopy when you actually go in with a camera. So an exploratory laparotomy is when you go straight down the middle of the abdomen, and then look at the abdominal contents and then try and fix what you can depending on what's going on. Myocarditis. Y'all got this one. Yeah. So I think everyone got it exactly right. So myo is muscle, card is heart, itis is inflammation. So myocarditis is inflammation of the muscle of the heart. Most commonly, it's caused by viruses. And it's an important differentiator because you have a lot of different types of infection. So you have endocarditis, which is the inside of the heart, which is most commonly caused by bacterial infections that actually get stuck on the valve. That's endocarditis, so inside this heart area. Myocarditis, which is the muscle of the heart, is usually caused by viral infections, inflammation, autoimmune processes. And then you have pericarditis, which peri is the outside of the heart, and is caused by a variety of things, most commonly bacterial infections, often after surgeries and things like that, where you sort of access the heart, and as a result of that, you have inflammation there. You can also get pericarditis after a heart attack because the arteries feed the outside of the heart, and as a result of that, sometimes you can get really bad inflammation on the outside of the heart after a heart attack. And then ophthalmoplegia. Yeah, so everyone got this exactly right. So ophthalmo is eye, plesia is paralysis. So ophthalmoplegia is a condition where the eye is paralyzed. So this is actually a specific condition. This is showing us intranuclear ophthalmoplegia, which is a really particular tract in the brain that allows for eyes to adduct, like we talked about earlier. And so what you see is that eyes can move out, but not in. And that's often a sign of multiple sclerosis. Is an important sign of multiple sclerosis, but can be seen in other things such as stroke. Thoracoscopic pneumonectomy. Yeah. So thoraco is thorax, scope is observed, pneumo is lung, ectomy is removal. So this is a thoracic camera guided removal of the lung. So there are different ways to remove the lung. So you can do a thoracotomy, where you actually open up the space between the ribs with a big incision, or you can do it with cameras, which if you gave me a choice, I would ideally choose cameras, although often it's not up to us because it depends on your anatomy and other things. But this is a special way of doing removal of a lung. And then dysphagia. Yeah, so everyone got this exactly right. So dys is abnormal, phasia is speech. Dysphagia is difficulty in expressing or comprehending speech and language. So there are a lot of different ways that people can have dysphagia. So sometimes it's being unable to hear what's going on and then not responding appropriately. Sometimes it's people being unable to speak or speaking incorrectly. So word substitution is a common type of dysphagia as a result of certain types of stroke. So this is sort of a general term to sort of being unable to speak or comprehend language. And then oropharyngeal dysphagia. Yeah. So this is a good example. So oro is mouth, pharynx is pharynx, dys is abnormal, phasia is eating. So oropharyngeal dysphagia is a much more specific term. So dysphagia with a G is difficulty eating. Oropharyngeal dysphagia is more specific to difficulty with either chewing or swallowing with that sort of oropharynx portion of the swallow protocol, right? So there are also esophageal dysphagia, right? Where food gets swallowed appropriately, chewed up appropriately, but then it gets stuck in your esophagus. And that's a very different type of dysphagia and requires a very different treatment. All right. So that was excellent. Thank you all for all of your willingness to engage and enter into the chat. We'll move on to anatomy next. I'd like to give you all a 5-minute break. I know we've been sitting for a little bit, so feel free to get a little bit of water, use bathroom, whatever you need to do. And then we'll get on to sort of anatomy since we've had a fairly prolonged period. And then if there are any questions about what we've done in the meantime, please enter them in the chat and we'll answer them for the next 5 minutes. So one of the questions that came up, so what's the difference in pronunciation between dysphagia and dysphagia? It's subtle, and I'm not sure anyone would be able to notice it. Dysphagia should have a little bit of a sort of j in it, whereas dysphagia is sort of like a sh kind of sound. But it's one of the common complications when we're sort of talking to each other, where we have to sort of be like, wait, what do you actually mean by that? It's much more clear when it's in the notes than it is when we're actually talking to each other. Yeah, great question. Perfect. Okay, I hope people are feeling a little bit refreshed and ready for some anatomy, which is a really tough but important topic. Anatomy has so much sort of minutia. There's so much just like different body parts, different like blood vessels, veins, nerves, etc. Just gets incredibly complicated. So the goal of this one is just to talk about the basics, and I think more importantly, be able to talk about sort of relative positioning of things. Because if you can tell me relative positioning of things, usually I can get exactly what you're talking about relatively quickly. And it has important diagnostic, prognostic implications. So I think being able to sort of communicate in that way, I think is really, really important. So let's go ahead and get started. So the first part of anatomy is to understand the anatomic position and our planes. So anatomic position is facing forward, and then most importantly, palms are facing forward. So that's really important in terms of differentiating front and back, right? So once you have that, then the rest is pretty easy, right? So anterior or ventral is towards the front. Posterior or dorsal is towards the back. So remember that dorsal fin is on the back of a dolphin. Superior means the same thing as cranial. So superior is towards the head. Inferior or caudal is going towards the feet. Lateral is going towards the side. Medial is going towards the middle. Proximal is closer to center. And then distal is further away from the origin. And proximal and distal and lateral and medial are relative terms. So it doesn't always necessarily, it means the body center, but you can talk about different things. So you can talk about, for instance, the ankle is distal to the knee, right? And that's not just, but the knee is actually distal to the hip. So they're all relative to sort of different parts of your body. The next thing you have to understand is tissue planes. So planes, not tissue planes, but planes, so anatomic planes. So anatomic planes come in most frequently with CT scans, which is where we get the majority of our anatomic information, right? I'm a medicine doctor. I don't cut into anything. I don't really like need to know my anatomy super duper well. But I should be able to speak to anatomy, and I should be able to know these planes. And where that comes up most frequently is with radiology. So let's talk about what the different planes are. So transverse is also called axial, and it's probably the most important CT plane. So this is cutting a person in the middle from inferior and superior portions, right? So you're cutting right in the middle, and then you have an inferior and a superior portion. And so that's what an axial or transverse plane looks like right here. A coronal plane cuts down the middle from front to back and divides a person into lateral and medial portions. So sagittal is right here. This is a really good example of what a sagittal image looks like. And then a coronal plane cuts a person from left to right. So I always remember coronal is like the sun. So it cuts just like this, from left to right. And so you can see so it divides a person into anterior and posterior portions. So when you're doing a CT scan, axial cuts are a series of cuts from top to bottom. Coronal cuts are a series of cuts from left to right. And then, sagittal cuts are a series of cuts from left to right. And then a coronal cut is a series of cuts from front to back. And then you're looking at those sort of anatomically. So let's look at some examples of this. I think this is really difficult to understand, but let's look at a couple of examples. So first, let's look at transverse. As I mentioned, this is the most important part of a CAT scan. It's literally what the CAT scan is known for, right? So it's computed axial tomography. By convention, know that radiology images are reversed. So left is right, right is left. And that's because it's as if you're looking at a patient rather than being the patient. So in this transverse plane, remember that we're looking at a series of slices of the patient posteriorly or superiorly to inferiorly, right? So you can imagine that this is a single slice. Coming out of the monitor is the head. Coming away from the monitor are the legs. And so this gives you 4 locations. So you have right and left, and then you have anterior or ventral and posterior. So this is how you sort of look at an axial image: right, left, anterior, posterior. Next up is sagittal imaging. So this is a series of cuts from lateral to medial, right? So you can imagine when you're looking at this image, the person's left is coming out of the screen, the person's right is going into the screen. And so this gives you, again, 4 locations. So anterior or ventral, posterior and dorsal, superior and cranial, and then inferior and caudal, okay? And then finally, coronal. So coronal, remember that you're cutting through a person from left to right, and then it's a series of images from the person's front to the person's back, right? So you can imagine that when you're looking at this image, the person's front is coming towards you, person's back is going away from you. And so that gives you, again, 4 anatomic positions. So you have right on the left, you have left on the right, you have superior/cranial, and you have inferior and caudal, okay? And so we'll go through a couple examples of this. I know that this is tough sort of when you first look at it, but once you get used to it, it really does, it helps a lot to be able to sort of talk through this stuff. Now, beyond just sort of anatomic positions, there are really 3 important anatomic cavities, okay? So there is the cranial and vertebral cavity. There's the thoracic cavity, which contains the lung and the heart. And then there's the abdominal pelvic cavity, which contains the organs of the abdomen, right? So stomach, small bowel, large bowel, liver, kidneys, etc., right? And those 3 cavities make up well over 90% of our CT scans. And so if you know what you're looking for in each of these cavities, you know sort of broadly where sort of anatomic positions are and what we're talking about, right? So the 3 CTs that we get most often are a CT head to look for abnormalities of the brain, a CT chest to look for abnormalities in the heart or the lung, and then a CT abdomen pelvis to look for abnormalities in the abdomen and pelvis. So if you get those 3 cavities down, you're in really good shape. So let's do a couple of quick checks then. So which is more caudal, the abdomen or the thorax? Yeah, so this is a tough one, right? So caudal means inferior, right? So heading towards the tail. So is the abdomen in this case. Is the palm dorsal or ventral? Yeah, so this is a tricky one. So remember, anatomic position is palm facing forward. And remember that forward is ventral. I can never remember ventral very well, but I can remember that dorsal is the back of a dolphin. That's like, that is my compass, is the dorsal fin. And then which joint is more distal, 1 or 2? Yeah, exactly. So distal is further from the origin. And so digit 1 is more distal. All right. Now let's look at sort of this CT scan. So which anatomic plane is this looking at? Perfect. Yeah, so this is the transverse or axial plane. What side of the body is the mass on? So this is looking at a big tumor in the lung. Love it. Oh, got it. So remember, right is left, left is right. So this is the right side of the lung. And is the mass lateral or medial to the heart? Yeah. So heart is right here. So it's this sort of sac in the middle with a bunch of blood vessels coming off of it. And so this will be the lateral, so further from center relative to the heart. So the mass is lateral to the heart. All right, same thing. What anatomic plane are we in here? Love it. So this is the sagittal plane. So how do you describe the location of the food bolus relative to the spine? So what I'm pointing to is, so this is your esophagus. This is a big old food bolus. And then this is your spine right here. So how would you describe it? Oh, I love it. So yeah, so this food bolus is anterior or ventral to the spine. What about the food bolus relative to the heart? So this is your heart right here. How would you describe it relative to the heart? Yeah, that's exactly right. So it's both posterior and superior. Excuse me, this should be cranial, not caudal. Whoops. So this should be and superior to the heart. So this is really important information to have when you're going in to extract the food bolus, right? Because you don't want to like go in and accidentally go through the front of the esophagus. Because if you go through the front of the esophagus, you're going to go straight into the heart and the mediastinum, right? So if anything, you're going to be a little bit careful and head more posteriorly, right? And it's very, very helpful. Now, it also helps to know, why is this food bolus here, right? So sometimes the heart can be so large, as in this case, that the heart can actually impact the esophagus and not allow things to pass through. And so this is an example of a very large heart leading to impacted esophagus. It's also relatively important because one of the things that we do is called a transesophageal echocardiogram, where we go into the mouth, into the esophagus, and we use an ultrasound to look at the heart. And the reason we can do that is because the heart is right in front of the esophagus. So really, really important to know. Okay, now great. So we have all these anatomic terms. How in the world do we use this in real life? So the reality is that anatomy is tough, but these terms make it easier. So you can figure out relatively quickly how to name something based off its position. And I would say 9 times out of 10, you're going to be right, right? So this is your cerebrum. So that's sort of the sort of most superior part of your brain. And it's the part that's sort of like regular, sort of wrinkly. And then you have the cerebellum right here and the spine right here. So the cerebellum is like the super wrinkly portion right at the back and bottom of the brain. And with that, like 9 out of 10 of these arteries you can name, right? So in the front of the brain is the anterior cerebral artery. In the middle of the brain is the middle cerebral artery. In the back of the brain is the posterior cerebral artery. At the top of the cerebellum is the superior cerebellar artery. At the front and bottom of the cerebellum is the anterior inferior cerebellar artery. And then at the back and bottom of the cerebellum is the posterior inferior cerebellar artery, right? So if you just know your anatomic positions, you've got 90% of your anatomy done right there. And you're able to communicate it relatively well. Beyond that, it also provides important diagnostic information. So in the cerebral cavity, so we'll start with just the cerebral cavity. Strokes are a really good example. So for instance, the middle cerebrum, which is this portion right here, and is fed by the middle cerebral artery, is important for movement, so frontal lobe, and then also language, so temporal lobe right here. And so a middle cerebral stroke often causes weakness and difficulty with language. And so this helps neurologists localize the lesion and then also determine exactly how large the lesion is going to be. Like if you have both weakness and difficulty with language, then you know that it's a bigger stroke than if you just have a little bit of difficulty with language. And so neurologists can use that to their advantage and be able to figure out exactly where it's going to be. Now, in the abdominal cavity, it really helps to be able to describe the patient's, if you can describe the patient's pain, then you can localize very quickly and be able to narrow your differential. So I'll just give you the right abdomen, for example. So in the right upper quadrant, right, so right superior, you have your liver and you have your biliary system. And so classic right upper quadrant pain is cholecystitis or gallbladder inflammation, right? And then right lower quadrant pain is where your appendix is. And so classic right lower quadrant pain is appendicitis. And so it really helps to be able to localize. If you come to a surgeon and say, this patient has abdominal pain, they're going to ask you, where is the abdominal pain? Because it really helps them to figure out exactly what you're talking about and what their differential might be. And then in the thoracic cavity, it's often what we describe as relative to the mediastinum. So the mediastinum is sort of the sac that covers the heart and is separate from the lungs. And when you have a tumor in the mediastinum, location matters, right? So anterior mediastinum is in front of the heart and is where your thymus and your thyroid are. And so the most common causes of issues there are thymomas and thyroid tumors. Whereas behind the heart, posterior mediastinum, as we talked about, your esophagus is there and your spine is there. And so neurologic tumors and esophageal diverticuli are some of your most common etiologies of tumors in the posterior mediastinum. So just by saying where something is, you give us just a huge amount of information. Even if we don't actually know what's going on in there, we can narrow our differential a lot more just based on anatomic position. It also provides important prognostic information. So this is an example of a heart attack. So a heart attack is when an artery of the heart becomes clogged. And we often describe the lesions as proximal and distal. So this is your left anterior descending artery, right? Also known as the widowmaker. It's one of the most common places where heart attacks happen. and it's incredibly deadly because it feeds a lot of the most important part of the heart, namely the left ventricle, which is the sort of powerhouse of the heart that spreads the blood to the rest of the body. You can imagine that if you have a proximal LAD lesion, which is way up here, that's going to feed most of the rest of that heart. And it's going to be much, much worse than if you have a distal LAD lesion, which just feeds a small portion of that muscle. So when you tell us a proximal LAD lesion, that is way, way worse than a distal LAD lesion in terms of prognosis. And it also matters in terms of how we're going to treat it. All right. So that was sort of anatomy. That was a rapid anatomy. Next up, I want to get into medical acronyms and shorthand. So the first question is, why in the world do we even use medical acronyms and shorthand? Right? It just adds needless complication. But I think the major reason why is it adds a lot of clarity relatively quickly when you're reading through a chart. So this is a good example. So a 65-year-old woman with a past medical history of hypertension and type 2 diabetes mellitus presenting with a right-sided anterior inferior cerebellar artery cerebrovascular accident, right? That is a mouthful, and it's incredibly difficult to read right off the bat, right? Whereas if you type this out in the chart, I get all the information I need in a couple seconds. So it's much, 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 much easier to read in the chart when you use these acronyms relative to the sort of long form. So you can just get so much information across relatively quickly. So let's go through a couple of these one-liners based on topics. So these are some of the important acronyms that we use and what they mean. And then we're just going to go ahead and go through them. So first off is an 18-year-old female with a PMH of CAD presenting with CHF exacerbation. What do you all think that's referring to? And we'll be relatively quick through these because we have a number of one-liners at the bottom. Yeah, so I'm seeing 85-year-old woman, coronary artery disease with congestive heart failure. That's exactly right. So 84-year-old female with a past medical history of coronary artery disease presenting with congestive heart failure exacerbation, right? So I do want to take a moment here. So separate from this, I also just want to point out the importance of a really good one-liner. So a good one-liner like this imparts a tremendous amount of information and all the pertinent information about a patient without having to dive deeper in the chart. So I can't tell you how much stuff gets missed just in like sub-segmenting patient information. Whereas if you have a really good one-liner, it makes life so easy and so much more relevant to the patient. So we use it a lot in history taking. So these are good examples of acronym used in history taking. So secondary to or due to, chief complaint, complicated by, concern for, consistent with. DOE is dyspnea on exertion. You see that relatively frequently. PMH is past medical history. PND is paroxysmal nocturnal dyspnea. So this is a heart failure symptom. So what happens when you have a lot of fluid in your body, when you're sitting up, that fluid goes down to the bottom of your body, right? It sits in your legs and things like that. But the second that you lay down, that fluid redistributes into your heart, into your lungs, and causes you to feel really short of breath. And so a classic symptoms of heart failure and fluid overload in general is lying down and feeling short of breath, which is called paroxysmal nocturnal dyspnea. PW is presenting with, SP is status post, and then SOB is shortness of breath. So another example here, so 84-year-old with PMH of CAD presenting with DOE and PND concern for CHF. So this is sort of broadening that one-liner like we talked about, right? So we said, oh, 84-year-old female with CAD coming in for shortness with heart failure exacerbation, but I want to know more. I want to know why this patient's here, right? Like what symptoms are they having that's leading to them feeling like we have a heart failure exacerbation? So this spreads it out. So 84-year-old female, past medical history of coronary artery disease, presenting with dyspnea on exertion and paroxysmal nocturnal dyspnea, concerning for congestive heart failure exacerbation. So you see how much more info is coming into this one-liner as we go, all with a relatively short single statement, right? All right, the next thing is we can use it for prescribing. So NPO is nothing by mouth. IM is intramuscular. IO is intraosseous. That's relatively uncommon, but we use it sometimes. IV is intravenous. PO is by mouth. PRN is as needed. QAC is before meals, often used for insulin. It's sort of the most frequent medication we use before meals. QAM and QHS is every morning, every night. BID is twice daily, and then TID is 3 times daily. So we're broadening it even more, right? So this is this patient, she's gotten admitted, now we're doing things. So 84-year-old, PMH, CAD, presenting with DOE and PND, concern for CHF, now status post Lasix 20 milligram IV with improvement, right? So now what we've done is we've given this patient with congestive heart failure treatment with intravenous Lasix, and she's feeling much better, right? And so we have all the information we need as far as what we've been doing for the treatment for this patient and why they're here. There are also a number of medications that we use as shorthand. So these are trickier. And in general, I tend to avoid them. The reason is that these kind of shorthand can become tricky. And there are only a few that I'll use frequently. So ASA is a really good one, which is aspirin. DAPT, dual antiplatelet therapy, is one we use relatively frequently. HCTZ, hydrochlorothiazide. NSAIDs are non-steroidal anti-inflammatory medications. That's ibuprofen, Advil. So Advil, Aleve, Naproxen, all the different terms, generics, are NSAIDs. A PCA is patient-controlled analgesia. So this is where you give patients a button and they press the button and they get a shot of morphine. It's very commonly used after surgeries. And then TPA is another one, tissue plasminogen activator. Short of these, I think usually using the full medication is important because you can get mixed up relatively quickly and you never want to give the wrong medication to a patient. So these are fairly accepted. Short of these, I tend to avoid them. So this is a patient with coronary artery disease on aspirin. So we know that currently being treated with coronary artery disease, but hasn't recently gotten a stent because she's not on dual antiplatelet therapy with dyspneial exertion PND. So again, gives you that sort of one-liner. Then labs. So labs are frequently used. So CBC is a complete blood count. A diff is the differential. So differentials separate the types of white blood cells. So when you look at the white blood cell count, usually it's a number between 4 and 10, and then it separates it into neutrophils, macrophages, eosinophils, etc. BMP is the basic metabolic panel. This varies by location. So at Stanford, the basic metabolic panel is sodium, potassium, chloride, bicarb, BUN, and creatinine, plus calcium, whereas other locations, BMP does not have calcium. So normally BMP is this. At Stanford, it adds on one thing, which is calcium. CMP is a BMP plus liver function tests. So your transaminases, your alkaline phosphate, your albumin. COAGs are coagulation studies. LFTs are your liver function tests. So a BMP plus an LFT equals a CMP. And then TFTs are your thyroid function tests. So this is giving us more information. So 84-year-old female with PMH of CAD presenting with DOE and PND with the CMP notable for AKI and elevated LFTs with concern for CHF exacerbation. So same symptoms, but now we know that this patient has a comprehensive metabolic panel that has elevated kidney markers and an elevated liver function tests, all of which fit a congestive heart failure exacerbation. And then finally, there are procedures. So AKA and BKA is above the knee and below the knee amputation. That differentiation is really important. Your functional status with a below the knee amputation is much different than an above the knee amputation, because having that joint allows you to add a lot more articulation. And so there's a big differentiation between an AKA and a BKA. BSO is a bilateral salpingo oophorectomy. Often that's combined with a TAH, which is total abdominal hysterectomy, and BSO, which is bilateral salpingo oophorectomy. CATH is catheterization. CABG is coronary artery bypass grafting. So that's when you have a diseased artery in your heart, and then you take another artery or vessel or vein, and then bypass that artery to be able to get blood flow to it. An XLAP is an exploratory laparotomy. PCI is percutaneous coronary intervention. TAH, again, total abdominal hysterectomy, often combined with BSO. And then confusingly, THA and TKA are total hip arthroplasty. So what that is a hip replacement or a knee replacement. That's what those two mean. So THA, TKA. And then VATS is video-assisted thoracoscopic surgery. So we talked earlier about thoracoscopic pneumonectomy. So the way they do that is with something called a VATS, which is video-assisted thoracoscopic surgery. And that's where you do those little video cameras that go in through those little ports and look at the lungs and then cut it out. All right, so we can use these to add on more information about this patient. So this is a patient with CAD, got a CABG on aspirin with dyspnea on exertion and paroxysmal nocturnal dyspnea coming in for heart failure. All right, so that was a lot of information. Oh, sorry, I have a question in the chat. So what is a TAVR? So a TAVR is a transcutaneous aortic valve replacement. So the way a TAVR, so up until recently, probably like 10, 20 years ago, the only, oh yeah, sorry. So up until recently, the only way that we were able to do aortic valve replacements, which are things where we take that heart valve and then put a new valve in, is by opening up the chest, opening up the heart, and then putting in a new valve, sewing in a new valve, closing the heart, closing the chest. But now what we can do is actually go through the groin artery, the femoral artery, and go all the way up there with this special catheter, and then basically balloon in a new valve over the old valve. And it's generally accepted as effective as aortic valve replacements in the correct subpopulation. So it's most commonly used in elderly patients with aortic stenosis, although it can be used for a number of different things. But that's what a TAVR is. All right, so this is all a lot of information, and I recognize that I'm not going to cover the majority of what you all will see on a day-to-day either conversation or medical record search, or even looking through a textbook. But how can I look these things up on my own? And I'm here to tell you that your best resource is Lane Library. Lane Library is just incredible. They have an incredible number of resources. I highly recommend these top resources. And in particular, I recommend Dynamed and UpToDate. So UpToDate is disease-specific information about pathology, epidemiology, diagnosis, treatment, and guidelines. It has excellent information at all levels. So it's very understandable, and it's bulleted and easy to get through. And it also has patient-specific information. So once you look at a topic, you can then look at the patient-specific information and then be able to pass that along to your patients who can understand it. And then Dynamed Plus is very similar to UpToDate, but it's a little bit more abridged. So it's a little bit sort of quicker to get through if you're looking for something. It has two different, like they're kind of two different ways of looking at the same thing. So it really just depends on which one you are used to or which one sort of fits your learning style better. The other thing I will say is that all these are accessible directly from Epic, thanks to Lane. And then Lane also has a way to get these as applications for you. So if you get on Lane's library, it'll have a sort of how to upload the app section, and then you can upload UpToDate or Dynamed onto your phone for easy access. There are also resources for shorthand and acronyms. So OneLook is really, really helpful in terms of looking through sort of the most common medical acronyms. And then just a Google search. If you type in, CHF part, usually you'll be able to find it relatively quickly. For labs, we use a lot of shorthand for labs. Stanford Labs actually has a really excellent search code that's specific to Stanford and what labs you're getting. So if you type in CBC, it will give you CBC, and then it'll tell you all the sort of different things that are within the CBC. And then if you're looking for information about prescriptions, Lexicomp and Micromedex are excellent. Lexicomp is actually part of UpToDate. And then Micromedex is a separate thing, very much available to us, but also very good. Okay. So next up, I want us to put it all together. So I have 5 one-liners. And again, these are one-liners that you would see in a patient chart that I would say to a colleague of mine right before I sign out, that I would say to a consultant when I call them and I say, here's the news on this patient and why I'm calling you. And so what I want you to do, so I'll give you 15 minutes to go through these with sort of the resources that I've given you, as well as whatever other resources you want. And I want you to put this in sort of a more simple format that's more understandable sort of broadly. So separate these out into what each component means so that it doesn't have any acronyms and that we have a much better idea of what's going on sort of more broadly. So I'll give you 15 minutes and then we'll go through each of them together. And for each one, we'll have you sort of send in the chat what you wrote out. Okay. All right, go ahead.
I will again pause the recording and then we will resume after.
Thank you. Awesome. Thank you. All right. So hopefully this helped to pull some of this stuff together. So I'll start with the first one. And y'all can either put them in the chat or just compare as we go through. So 26-year-old F with PMH of SLE, CB, ESRD, polyarthritis, and steroid-induced T2DM. PW, right, RUQ tenderness with elevated LFTs, CF, MTX-induced hepatitis. That is incredibly difficult to say out loud. So I love it. So y'all are exactly right. Oh man, yeah, y'all nailed it. So 26-year-old female with systemic lupus erythematosus, complicated by end-stage renal disease, joint inflammation, and steroid-induced diabetes, who is presenting with right upper quadrant abdominal tenderness and lab findings concerning for methotrexate-induced liver inflammation. So as much as possible, trying to get this as accessible of language as possible, I think is really important to be able to disseminate this information broadly, not just to providers, but to patients and everybody else. Next up is 55-year-old male with PMH of HTN, HLD, CKD, and AFib, not on anticoagulation, presents with new onset hemiplegia, time for CVA, now status post IV TPA. Perfect, I love it. And I love how some of y'all simplify that cerebrovascular accident, because I think that's exactly right. Like you say that to a patient or even some providers, and they would have no idea what you mean by that. So this is a 55-year-old male with a past medical history of hypertension, hyperlipidemia, chronic kidney disease, and atrial fibrillation, who is not on anticoagulation, who presented with new onset partial paralysis, concerning for stroke, for which he received a clot-breaking medication, right? So nice simplified language here. Next up is a 67-year-old male with PMH of CAD, status with PCI on DAPT, presenting with DOE, the setting of dark bowel movement and anemia on CBC, center for UGIB. He is receiving IV protonics and his NPO, pending esophagogastroduodenoscopy in the morning. So yeah, y'all are saying exactly the right things here. Perfect. So this is a 67-year-old male. He has a past medical history of coronary artery disease, which he received a percutaneous coronary intervention. So he had his arteries opened up and remains on dual antiplatelet therapy, for who is presenting for shortness of breath on exertion, dark bowel movements, and low blood counts, concerning for an upper gastrointestinal bleed. He's receiving intravenous protonics and is not allowed to eat, with plan to evaluate his upper gastrointestinal system more closely with a fiber optic camera in the morning. All right, so 45-year-old female, no significant PMH, presenting after motor vehicle accident with imaging concerning for rib fracture complicated by hydropneumothorax and pneumoperitoneum, now status post thoracotomy and XLAP, recovering in the ICU on a PCA. So this is sort of a good example of, we're not even using a ton of acronyms, but you said this to a patient and they would have no idea what you mean. And you said this to a lot of providers and they have no idea what you mean. So let's simplify this out a little bit. So this is a 45-year-old female with no significant past medical history who had a motor vehicle accident resulting in air and fluid in the lung and air in the abdomen, for which she underwent exploratory surgery of the chest and abdomen. She's recovering well with patient-controlled pain management in the intensive care unit. So next up is a 63-year-old male with a PMH of COPD on home oxygen who is presenting with cough and DOE, concern for PNA, now improving on IV CTX. So simplify this even further. So 63-year-old male, past medical history of chronic obstructive pulmonary disease, who is presenting with fevers, cough, and shortness of breath on exertion, concerning for pneumonia, who is now improving on IV ceftriaxone. Now, all of these are like, there are many different ways that you could communicate these results. So I don't mean to say that this is the only way that you can state this in sort of a simplified term, but I think it's helpful to think about like, what are we truly saying and how do we communicate it to different people? So a couple of tips for that is know your audience. So never speak like you write, right? Like you saw how difficult it was for me to say all those terms. So, you know, sitting there and saying DOE is just not going to get you very far. So it's really important to separate how you speak and how you write. Some abbreviations are discouraged. So U shouldn't be used, QD ideally shouldn't be used. MSO4, which is morphine, generally shouldn't be used. QID is another one that's generally discouraged. And there are a number of these that get confusing because they overlap with other acronyms. And then most importantly, remember your audience. So medical lingo is great for communicating with medical professionals, but normal English is best when talking with patients and families who speak English, I should say. And ideally using an interpreter, Gloria read my mind, when you are speaking with families who their first language is not English. And I really can't stress that enough, that you have to speak at the level that patients understand. And this is a sort of a rough study which showed that 99% of Americans can read, but only 12% are health literate. And 50% of patients leave their doctor's office not knowing what they were supposed to do, which is just horrible. Like, what is the point of taking care of patients if 50% of patients don't know what we're trying to do? So it's really, really, really important that we speak at the appropriate level to be able to get patients to follow our recommendations. I saw a tweet recently about a patient who presented to the hospital and was shocked to hear that the cancer was getting worse because her oncologist kept saying that the cancer is progressing. And she took progressing to mean that it was getting better. So knowing what you're saying, knowing how people are interpreting what you're saying, and most importantly, teach back, where you ask patients to speak back what you said and make sure that that level of understanding is appropriate and is correct is really, really, really important. And then finally, just identifying patients who are at high risk for poor health literacy. So adults over the age of 65, racial and ethnic groups other than white, recent refugees and immigrants, people with less than high school degrees, people with incomes at or below the poverty level, and then again, non-native speakers of English. So this is all, it's important to recognize this up front and be able to adapt what you say, how you say it to your audience, because ultimately what we want is the best outcomes for patients. And the only way we're going to get that is if they understand what we're saying and why we're saying it. So that's all I have. So I'll leave a solid 2 minutes for any questions people have. And I appreciate your attention and your willingness to sort of work in this modified format and be so involved as we went through these cases and these discussions.
Thank you. Thank you so much, Andrew. Really appreciate it. This is a fascinating topic. And as I said, the most popular one. And you do such a fantastic job presenting it and breaking it down, so simplifying it that it makes it so much more absorbable for everyone. So thank you. And thanks for sharing your slides and the resources. Everyone, please, as I mentioned, I will be sending out an evaluation. I'll put it in the chats here as well. I will email the slides along with the reference guide, the quick reference guide, and the evaluation. If you are collecting BRN credit or any continuing education credits, please make sure you mention your name in the evaluation so we know who is requesting certificates. And we will have the recording available on our website in a couple of days. I will share the link to our website in my email as well. So thank you so much, everyone. Thank you so much, Andrew. And I really appreciate your time. Hopefully we will again be able to repeat this topic with you in another year.
Awesome. Thank you. Thank you for having me.
Thanks everyone for participating.
Hi, Susan, I have a question. So I took this course as a requirement or elective for the CROP for clinical research certification. Mm-hmm. How would I go about getting a certificate?
As I mentioned, you need to complete the evaluation. I put the link in the chats and I also will email it to you.
Okay.
You need to mention your name in the evaluation and then you will receive the certificate. But of course, it takes a month or so to issue the certificate. Sometimes even if there's a backlog longer than that. But we will get the certificates to you.
Okay, thank you. Thank you.
Absolutely. Any questions for Andrew? Okay, so thank you so much. Have a lovely day. Thanks again, Andrew. Really appreciate it. And Kira was able to join as well. So you know that we host these classes along with Kira. So we both really appreciate your time and willingness to participate and to partner with us in this. Thank you so much.
It's my pleasure. Next up, pulmonary.
Yes, we'll see you hopefully in a couple of months.